What I would like to focus on today is to talk about some of the very natural challenges that arise in how we collaborate. And I would like to show you some ways that we can use these challenges to create learning dialogues. And then at the last part of being together, I'd actually like to brainstorm about how we can actually make our environments more collegial, because it's not just about the skill set of the individual practitioners. So I'd like to actually try and focus us on your work. I have a small understanding of what you do. I'm a palliative care physician, and I only provide care out in the community. And what I do now is actually offer supportive counseling to patients and families. So when one of my colleagues at the Temi Latner Center is encountering a family or a patient who might need a little more time to talk and figure out what their own internal supports are, they call me. So I certainly do have experience with trying to provide care in the community, and I know the challenges that that entails. But if I really think about what are the really key elements of being able to work really well together and work together on a team, I think really being able to demonstrate respect for one another and to have an understanding of what shared decision-making is going to be. So how do we really get the input of the people that we work with and the perspective? But conflict is something that comes up in both of these situations, and if not acted with skillfully, can really interfere with our ability to be respectful and to have shared decision-making. So if we think about the role of conflict, we all have different responses to it. We all grew up in different households. I actually really like arguing, and so does my son. And my daughter and husband will sit at the dinner table rolling their eyes, looking at their watches, because this is not what they like engaging in. Some of you out there may have come from households where a raised voice meant that there was going to be physical harm. So we all sort of bring different reactions and different skills when we're thinking about conflict. But really, conflict is natural and it's unavoidable. So let's work with it. Because if we don't have conflict, we need to wonder, if we're all yes people, then we're probably missing opportunities to be challenged and to learn. If we have too much conflict, then that can be a really toxic environment and nothing really grows there. But you know, before the times of reality television, back in the 60s, they actually did an experiment, and this was in business, and it was called the Devil's Advocate experiment. And what they did is they had different teams working together on a business problem. And half of the teams just worked together naturally, and half of the teams had somebody there who was asked to be a devil's advocate. So to challenge the status quo, to try and bring up other ways of thinking about things, to really stir the pot. Now, at the end of it, perhaps not too surprisingly, the teams that had the devil's advocate had more creative business plans than the teams who did not. Unfortunately, the second part of that study was allowing everybody, every team, to vote out a member of their team. And who do you think that was? So it was a devil's advocate. So we sometimes don't appreciate those colleagues who challenge us, and maybe we should. So what do we know about conflict on teams? So this was a study, it doesn't exactly represent what you're doing. This was looking at about 16 different family health teams of various configurations in Ontario. And they interviewed 121 people. About 25% of them were physicians, 30% of them were nurses, 11% were administration, and then about 6% of social work, pharmacy, dietitian, and other allied healthcare providers. And these are the main conclusions that they found by asking people, how do you deal with conflict? They didn't define it or anything, they just really had a very open conversation. And so, you know, sources of conflicts on teams, I don't think these are any big surprises. You know, trying to understand what the boundaries of our individual roles are. Where do we share responsibilities and what might be unique to our profession or our personhood? And that sort of fits over into scope of practice. And then also accountability. And this is a really big thing that I think we're still trying to wrap our heads around. What does team accountability look like? And what does that responsibility really entail? But they also identified that there are barriers to really dealing well with conflict. And lack of time and being too busy was the number one thing. The way they described it was that people in less powerful positions may not feel empowered to actually speak up. So the role of hierarchy or perceived hierarchy can sometimes really get in the way. And then because we're all really good people, we don't want to hurt somebody's feelings. And so if we feel like we can't do it very skillfully, we might not do it at all. But there are things that worked. So a lot of the discussion was, what are the expectations of a leader to set the tone and really walk the walk? And beyond that, having a conflict management protocol. And that may be quite as simple as deciding that everybody tries to deal with the conflicts at the source. So when it happens between you and somebody else, you're the one who really needs to try and deal with that. And maybe you ask a buddy, and maybe you know how to escalate it should you need to do that. So it doesn't have to be really difficult. See some smiling faces out here. And then some individual skills. And one of the skills that came up that I thought was really important was humility. I think that is very important. And humility has the same root as human. So people who are really human. So what about Casey House? I did send out a little survey, and thank you to the 40 of you who actually answered this. This is not scientific. It presents a little snapshot into what some of you people have experienced. So when I asked about receiving feedback at work, the majority of you actually found it very helpful, which is fabulous. About 30% of you didn't find it helpful or unhelpful. It was kind of neutral. And a small percentage of you found it unhelpful. So I think this is actually a very healthy response, and it just shows that there is some room for improvement. I asked you, what were the conversations that didn't happen? So number one is concern over treatment plans, and number two is disrespectful behavior. And I think this really just fits into what I was talking about respect and shared decision-making as being really key in collaboration. And the barriers to conversations, it won't be effective. There's a perception of hierarchy, and we're busy. We have a lack of time. So not that dissimilar from the previous study. And just to remind you, and I'm not going to spend a lot of time on this, but there are different ways and different styles of responding to conflict. And not all styles work in all situations. So, for example, if my 2-year-old daughter is going to run out onto the street, I am not going to have a conversation with her about what the right thing to do is. I'm going to be incredibly assertive and just use a competing style and pull her off the street. If I'm talking to this same daughter and, she wants something for dinner and it's not really what I was thinking about, I can be kind of accommodating. I don't really want to do it, but I can do it. It's not really all that important to me. Avoiding might be a very skillful response. when my husband says something to me and I want to wring his neck is probably not the right time to have a conversation. However, on teams, what we're really aiming for most of the time is collaborating. So that's really trying to work towards a win-win combination. But the winner is avoidance. So when you look at the styles that we actually use, it's really avoidance. And I'm not trying to pick on nurses here by putting up this study. I actually think it's a testament to the fact that nurses pay way more attention about how they interact with each other, and they're actually curious and interested about this. So I couldn't find one looking at physicians, for example. But there is a very interesting study, and it's called Teaching Compassion and Respect. And this study was about watching physicians who were teaching residents and medical students, watching them to see how they handle disrespectful behavior. So for a month, they had researchers following 4 general medicine teams in an acute care hospital. And they were very upfront about what they were doing, and they talked to faculty ahead of time about, how they normally handle these situations. And the faculty were, had all sorts of strategies for how they handled it. And what the researchers observed is that the most common thing that happened when there was disrespectful behavior was no response at all. No response at all. The second most common response was kind of taking the focus away from the disrespectful behavior to the problem at hand. So, well, let's talk about the blood pressure. So physicians aren't very good at this. And there's one great story where, and this is there are people watching, a patient discharged themselves against medical advice in the morning. Showed up in emergency, let's say at around 4 o'clock. And the faculty member said to the resident, well, I guess you're going to have to go and readmit this patient. And the resident said, I can't believe I need to admit that scumbag again. So, the researchers are watching to see what happens, and they didn't see anything. So they went to talk to the faculty member, and they said, so how do you think that went? And the faculty member said, oh my God, I was so clear. I am normally a very talkative person. Well, I was sitting like this, and it was pretty clear that I found that behavior completely unacceptable. And they went to talk to the resident, and the resident goes, oh my God, my faculty member totally agreed with me. They just didn't have the guts to say it. So physicians aren't any better at this either. And we need to remember that conflicts are ubiquitous. They're all over the place. And sometimes instead of avoiding, what we do is we just don't see them. But I really want to emphasize the point that they really are very common, and so we really need to be skillful about how we handle them. And there's many reasons for this, not only that they're common, but healthcare practitioners who are confident in their ability to raise crucial concerns observe better patient outcomes, work harder, are more satisfied, and are more committed to staying. So this comes out of a study where they interviewed close to 1,800 nurses, physicians, and residents. Now, they were working in a critical care, and what they found is that about 3/4 of all medication errors were because of poor interpersonal communication. And when they're looking at this and they're asking people, well, why didn't you bring it up? Why didn't you talk to me about it? And it might have been something like, well, the last time that I called them at home, they shouted at me, so I didn't want to call again. These are the types of barriers that we encounter. But what they found is there was about 10% of people who just had this natural ability to have conversations and get better outcomes. And so what the researchers did is they actually looked at what were the common behaviors of these people. And they found that they had, I think the most important thing was when they started a conversation, they were very clear about what they were hoping to accomplish and that they were really trying to have a conversation for the greater good rather than trying to be right. And out of this, they developed crucial conversations, which if you ever have a chance to take, I found incredibly useful. But the other thing that these researchers found is that these are 7 conversations that we really like to avoid because they can be really uncomfortable. Things like people not following the rules, making mistakes, when you need support and it's not there, teamwork and team decisions not going as well as they could, disrespect, or having somebody who's micromanaging you. These are some of the conversations that I'm talking about that are really integral to how we work together and are very integral to safety. Now, you might be saying to me, well, you know what, we don't have a lot of problems with medication errors. But I think if we increase the scope of what I mean by safety, think about the patient interactions that didn't go well and they're feeling diminished, or interactions with each other and we feel not valued and we hold back our contributions. So let's really expand what we think about safety. And also think about resiliency, because I think these conversations are very intimately connected to our ability to discuss this, because these conversations are a way of looking after ourselves and looking after the other. So what do I mean when I say collegial conversations? Well, collegial means marked by a spirit of camaraderie and friendliness. It's something we all aspire to, and a lot of our team interactions are collegial. But these conversations can also be a way of getting accountability from each other and also a way of expressing our caring. And I think one of the ways to really make sure that this happens is to really frame these conversations as a learning issue. So how can you approach a learning conversation? One of the tough conversations that I had, and I'll tell you one with a peer, because having ones with students are a lot easier. Not to say easy, but most of us feel, oh yeah, I could have that kind of conversation. But this was with a peer. So this was when I was actually providing palliative care services in an acute care hospital. And we had a patient who was admitted from the community whose lung was full of fluid. And this gentleman probably had a prognosis of about 6 months. So he came through emergency, he was admitted to surgery, and he was taken for a procedure where they took the fluid out. They injected something into the chest wall so that the lung wouldn't be able to be compressed by fluid anymore. Now, I was on call this weekend, and what happened was the surgeons did this procedure and took out all this fluid, and the gentleman really struggled. He wasn't doing well, he wasn't peeing well, he was in pain, and it was the surgeons who were looking after him, and I was really trying to advocate for his care. And I constantly had to page them and saying, look, this isn't good enough, come back and take a look at this patient. And the patient, after about a week, died. And he died in hospital, and that's not something that he wanted to do. And I really felt like he hadn't had the best care. So I actually ended up calling the chief of the surgical service, and I said, you know what, I'd really like to talk about a case that's really troubling me. And I'd really like to learn from it and make sure that it doesn't happen again. So I framed it as a learning issue. And I tried to create some safety. So I gave him a heads up, this is what I wanted to talk about, and I made an appointment to see him, so it was on his turf. I knew it was a time that was going to be convenient for him. And, you know, we explored things like asking open-ended questions. So, you know, I started with, so this is my understanding of what happened. How was it for the residents? What are you thinking about the care that was provided? And when we actually started unpacking it, he was actually upset too at what had happened. And he said, you know what? We saw that word palliative and we thought, well, he's at the end of life anyway. That shouldn't have happened. That won't happen again. If this, next time you're bringing one of these patients in, you call me and let me know, and I'll make sure that my team treats him with the respect that he needs. And we ended up having a really good conversation. And what would happen was that whenever we saw each other passing in the hospital, we'd usually stop and talk. And I have quite a collection of glasses, and some of them are really out there. And he'd always notice the glasses that I wore. So this very difficult conversation made me feel better, got better patient care for the next patient, and solidified our relationship. And when we are professionals, I think intention and impact is a way of thinking about, should I have a conversation or not, and what are my professional responsibilities here? Because sometimes if we're feeling uncomfortable and we're wanting to avoid a conversation, we have all sorts of good reasons why we do that. And we haven't really thought about, maybe it's my professional responsibility to have this conversation. So I think to think about yourself, how are you feeling about what's happening? What's the impact on the patient? And sometimes the patient gets totally lost in these conversations. What's the impact on our colleagues? And, if somebody from the lay public were watching this encounter, what would their expectations be of how it was handled? So this is something that we use with medical students to help them make good professional decisions. And I think that whole idea of intention and impact is helpful when you're planning to have a conversation. So, if you go in there in a confrontational manner, even if your intention is to solve the conflict, the likely impact is going to be it's not going to go well. So you have to sort of think ahead. Because this is the role of collegial conversations. It's creating this learning dialogue. We are in this together. What's the skillful thing to do here? And if you think about the impact of the second conversation, you can imagine that Frank, and that's my colleague's name, Frank is feeling better. I'm feeling like I didn't leave somebody in distress. So the team is going to be working better rather than I didn't say anything and I'm kind of embarrassed when I see Frank again. And the patient outcome is better because you actually problem solved about how to prevent this happening for the next patient. So you feel better about yourself. And the practice improvement is possible. So these are really potentially very powerful conversations. But let's look at alternatives. And let's look at ineffective alternatives. So, silence is certainly one option, and nothing is going to change with silence. One we tend to do a lot is we talk about the situation or the person to others. Rather than going directly to the person, we may go to somebody else. Now, sometimes one needs to ventilate, and sometimes you need to have a safe space to talk with a trusted colleague about how to proceed in a situation. But a lot of it is actually gossip, and it's not helpful, and it doesn't go anywhere. And then there's this issue about blaming people higher in authority for not fixing the problem. And that's what Frank tried to do. Somebody should be doing something about this, where he was the one, because he was closest to the situation, who actually had the power and the ability to do it. And then we pretend it isn't a problem and work around it. And we're really good at this in healthcare because we're practical, we want results, so we just move and do pretend that it's not a problem. So again, it never gets solved. And then the other thing is that okay, good for us. We decide to have that conversation. So we just gather ourselves up and go and just on Frank, and then we wonder why it doesn't go the way that we wanted it to. So really, when we think about what are some effective alternatives, it's sometimes it takes more than one conversation to resolve a conflict. And you can see in this last one that we had our conversation. Frank talked to the nurse. Frank ended up talking to the unit manager. He had to talk to Emerge. He talked to his physician colleagues about how they could make changes. So it initiated a lot of conversations. And if you're feeling like, oh my God, if I enter into this conversation, I'm going to have to solve it by myself, that's overwhelming, and that can certainly be a barrier. And sometimes if you don't feel you have the ability to enter into that conversation, asking a question can be incredibly powerful. Even, can we talk about this? Because, you know, sometimes when people are in a position where they feel not as powerful as the person they're talking to, that asking permission, can we talk about this, can be an opening. Sometimes we make assumptions that you can't talk about it, and this just opens the door. And really trying to get underneath at the value. What value does this decision or action support? You know, if you're at a meeting, there's lots of people around the table, and you can just see the meeting going down the tubes, this can be a really powerful question to throw out there. But why is this sometimes so hard? Well, I think that we are still learning about how to work together as a team. And physicians, the new ones that are coming through, learn about team-based care and interprofessional education, but old farts like me never had any of that. When I went through training, I was told the buck stops here. You're the one who is responsible. And so as we share with other people, sometimes we still feel that I'm the one who's responsible, and we haven't really wrapped our heads around what does it really mean to be a team, and what does team accountability look like. And I think we're really moving in that direction, but it is incomplete. And sometimes we have unclear as to what are our professional responsibilities to colleagues. And certainly when I teach at the Department of Family and Community Medicine, and you know, we have pharmacists, nutritionists, social workers who are working together, I get a lot of pushback about whether they have any responsibility to step in when they see a learner who is acting disrespectfully. But I think we really are responsible to people on the team, regardless of what professional hat we're wearing. And certainly, and I will say this for medicine, there's a lack of value placed on these soft skills. And I would imagine that in social work, people get how important these skills are. Sometimes we don't practice this, and sometimes we prefer to avoid conflict. But the underlying reason is really fear. We're human beings. And sometimes if we have these conversations and we're not really careful, we feel judged, and our threat system goes right up. I'm not sure if you would agree with this or not, but certainly from my days in working in acute care, this really resonated. Most people at work are doing a second job that no one's paying them to do, preserving their reputations, putting their best selves forward, hiding their inadequacies. And I think we probably do that to a certain extent, and much less so when we're working with colleagues that we trust and we feel that we can be vulnerable with. But this is an interesting way to think about it. Paul Gilbert is actually a gentleman who teaches about compassion-focused care. And he talks about how this is sort of neuroscience 101, incredibly simple, and it's not exact, but if you think about it, there are three different emotional systems. So our threat system is that very primitive part of our brain, that fight, flight, or freeze. And when we're in our threat system, our thinking is like this: whoop, how do I make myself safe? That's all that we're thinking about. We're not thinking about the patient. We're not thinking about our colleagues. So the trick is, how do we get out of that and actually be able to work collaboratively? Well, if we're in our drive system, that's the system that gets us to get food, water, sex, status. It is still pretty about us. It is still pretty self-focused. So if we're protecting our reputation and our status, we're not really attuned to the other. And this final, what Gilbert would call affiliative system, is the most evolved part of our brain. And that's the part that is mediated by the parasympathetic system, and it's mediated by the frontal orbital cortex, the wise part of our brain. And when we get in that part of our brain, we're able to see the wider perspective, we're able to tune into the other. So the whole trick is, how do we shift from the threat system to the affiliative system if we're really wanting to work collaboratively? What is the antidote to fear? It is compassion. So it's that ability to be open to the reality of suffering and aspire to its healing. And if we think about the people we work with, are we competitors? And I can tell you in medicine, very often we are. Medical students are competing against their colleagues to try and get the residency that they want. Are we friends? Are we fellow team members? And really, what would our work be like if we were trying to be as compassionate to our colleagues as we are to our patients? And if we really want to get radical, as compassionate to ourselves as we try to be to our patients. And why is it so hard to be compassionate anyway? I would actually recommend that you look this up. It's a TED Talk given by Daniel Goleman, and he is the author of Emotional Intelligence. And what he would tell us in this lovely little video is why it's so hard to be compassionate. And he talks about a study done at Stanford Theological College. And in this, the theology students were in this experiment, and they were told to prepare for a sermon. And half of them were told to prepare for a sermon on the Good Samaritan. So the story where somebody stopped and provided assistance to a complete stranger. And the other half were given a sermon to give on some other story from the Bible. And then at a certain amount of time, the students were told that they had to go to this other building and give their sermon. And when they actually walked from one building to another, they all had to pass this gentleman who was standing and going like this and in obvious distress. And what they were interested in was, would the students who had been working on the Good Samaritan, would they be more likely to help than the students who hadn't? And that's not what it was all about. It didn't matter what sermon they were preparing for. It mattered how busy and rushed they felt. That was what decided it. And I mean, that is something that happens in many areas of our life. When we're so busy and stressed and focused, then there are things that we absolutely miss. And if you think about healthcare and how we really value expediency and being fast and getting things done, you can see that there's a natural challenge to being compassionate. So moving forward, these conversations can be tough, but they're beneficial. They need safety. And these are two things that you might think about, mutual purpose and mutual respect. And if others perceive that we're working towards the same goal, then it's much easier to be collaborative. But when they're defensive or pushing back or silent, then it's not there. And if they don't feel that we respect them, then the conversation isn't going to go anywhere. And that's when apologizing, to say something like, I didn't mean to imply that you were wrong. I did want to find out how we can work together on this. That would be a contrasting statement. And you start with the don't, because that's what they're going to hear first. And you don't go but in between, because if you put but in between, then anything you said before. So I don't want to imply that you're at fault, and I do want to figure out something together. So can you respect everybody? Sometimes it's hard. And that's often in a situation where we're focusing on how we're different rather than how we're the same. And especially if we're dealing with someone else in healthcare, you know, the patient could be that thing that unites us apart from our own humanity. And this question comes from Crucial Conversations. Why would a reasonable, rational, and decent person do or say this? So let's move a little bit beyond technique to actually think about self-care. And I'll offer you this as something that I think is very helpful. And this is Joan Halifax, who is a rather fierce woman in palliative care and from a Zen background. And she talks about the grace intervention as a way of really being kind to yourself and gathering yourself to actually have a difficult client or patient encounter or a challenging encounter with a colleague. So gathering attention is really just trying to pull all of your scattered energy here. Feeling your feet on the ground, feeling the breath in your chest, touching your heart, noticing where your mind is at, and pulling it into the present. And then R is recalling intention. And if we're talking about these conversations, we don't have the right intention, they're not going to go the right way. So can we have the intention of having a learning dialogue, of suspending judgment, and actually being open to the other person? So then we move on to attuning to the self and attuning to others. What's that magic that can happen between two people? Because if that attunement doesn't happen, then the patient or your colleague is left with it as their problem. And if this is something that you actually share, it becomes the problem between the two of you. And then considering is using your practical wisdom to come up with what will serve in this moment. And engaging is do what you said you would do, and the E is also for ending. So how do you let that go as you move on towards your day? So there's beyond technique, and then there's beyond the individual. And the environments in which we work have a huge influence on our ability to engage in these conversations. So do you have any idea about how we could create more collegial environments? Is this something you've thought about? Well, I'm going to make a few suggestions for you. Let's talk about psychological safety. Let's talk about shared decision-making supports, team practices, mindfulness, and organizational ethics is there, and I'm not going to talk about that today. But psychological safety is that extent to which individuals on a team feel safe to actually be a little bit vulnerable by floating a new idea, by speaking up, by asking for feedback, by offering to give feedback. And if there is that psychological safety, then that feedback flow is much better, And they're much more willing, teams are much more willing to look at, so what is it that we're trying to do and how are we actually doing? That doesn't feel quite so threatening. And these are, just for your information, some interesting questions to ask on your team. This is a way of measuring it. So, great questions. When somebody makes a mistake in this team, it's often held against him or her. In this team, it is easy to discuss difficult issues and problems, so some of the questions are positive and negative. In this team, people are sometimes rejected for being different. It is completely safe to take a risk. So these are questions that you can ask on your team and see what kind of answers you get. And there are actually shared decision-making supports. And a number of you pointed out, it shouldn't just be, well, the nurse's opinion, the doctor's opinion. It has to be a collaborative way. And so a decision-making tool is kind of like saying, we are going to agree on the process. We're going to agree how we make this decision. And so on a team, it is unlikely you will get everybody to agree, but they might agree to support it if they feel that the process was safe. And there are some lovely ones. So this ethical decision-making worksheet, I'm only showing the first page here. This is something that was piloted and used at CCAC, and some people in the community are aware of it and some people aren't. But this is a way, number one, of collecting good information. And if you don't agree on the facts, then it's kind of difficult to imagine you're going to agree on the solution. And I've included in your handout a link so that if you actually wanted to download this, you could. But just some simple things like looking at the medical indication, the client preferences, quality of life, and contextual features. So first of all, get your information. And then generate, so what are the problems here? And what are the solutions? And looking at pros and cons. And you'll find that you generate many more possibilities when you have more people around the table. And this isn't something you do every day, but this is something that you do when there is disagreement and there's really a lack of clarity. And this is what team accountability can look like. You can get everybody to sign off on this, and it's a way of including people. This is also a document at CCAC supporting clients' choices. And there's a lot of information in here, and they even have algorithms that you can go through when you're trying to make a decision that is going to be a risky decision out in the community, and really forces you to look at how can you mitigate harm. And again, it might be a way of, as a group, deciding how are we going to make this decision. And team resiliency practices, like simple things, like checking in with each other, like creating opportunities for participation. And this might involve, at one meeting, you do take a piece of paper and you mark everybody around, and you take a line and say, okay, this person talked to this person, talked to this person. And if you find that there are people there who haven't said anything, or people who are really dominating the discussion, you can talk about that. Appreciation practices, huge. That should be part of every meeting. Ongoing role clarification. And another one is, what is your process for monitoring and learning from mistakes? And again, I'm not talking just medication error. I'm talking about poor client outcomes and poor client encounters. And as the study that I talked about in the very beginning, do you have a conflict management guideline or protocol, or even an expectation that it is your responsibility to initiate a solution? And then, of course, social interactions outside of work. And mindfulness as a practice for individuals is something that can be very helpful. And this study actually looked at teaching mindfulness to the team. And what they found was that it really reduced role conflict because people could talk about it. And one of the things that mindfulness does is it allows an individual to tolerate more difficult emotion. And that can be very helpful, as you can imagine, in dealing with conflict. So back to Casey House. For those 40 of you who answered, I said, so are you having these conversations that went well? And here's just a handful of the ones that went well. Renegotiating equitable job assignments, dealing with disrespectful behavior, providing feedback. 5 people said yes without giving me an example, and only 2 people said no. They could not think of an example of a conversation that went well. So, I think we can actually engage in conversations without judgment and without thinking that making a mistake is always bad, but really framing it as a learning issue and really valuing difference and conflict as an opportunity to grow and get better. And I think we also really need to think about how do we create environments where our compassion for our clients, for our colleagues, for ourselves is likely to flourish. Thank you.